All right, welcome everyone to another EBFA webinar. My name is Dr. Splickle. I am the CEO and founder of EBFA, as well as a functional podiatrist and a human movement specialist. The topic that we are going into today is one that I find is very important. It's one that there's actually a lot of confusion around the midfoot and what is happening from a pronation perspective in that midfoot, and how is it different from the rear foot? And then really the big question that I get a lot is, can you correct this foot type with just corrective exercise and foot strengthening, or where does this kind of structural component come in? Where do orthotics come in? Do you need orthotics? So all of those are going to be answered in today's webinar. And I see this a lot, which is why I specifically wanted to do this webinar. I mentioned briefly my background, but if you want to learn a little bit more about EBFA's education and our certification, we also have continuing ed courses that are a little bit smaller. Please go to ebfaglobal.com. I will mention a discount that we are offering in behalf of this webinar. That will be on our online courses. So I'll mention that towards the end. If you have not read my book yet, Barefoot Strong, it's available on Amazon. You can also go to barefootstrong.com and I'll link out to a couple other places that you can purchase that. And then of course, Naboso. All right, so to set the tone for the webinar, why is understanding navicular position important to our client programming, or our own understanding of our feet, and athlete performance? My apologies, I should say performance, not performing. Okay, so understanding navicular position and client programming and athletic performance. What is happening with the navicular and really the talonavicular joint, which is going to be our midfoot that we are referencing, and how does that affect foot posture, foot stabilization, and then everything further up the chain? Okay, now there is an assumption that all feet can be corrected and strengthened to a neutral arch. And to set the tone again, I am a functional podiatrist. I bring a majority of my patients out of orthotics into natural minimal footwear, into foot strengthening, into a sensory rich environment. However, there is this assumption that all feet can tolerate minimal shoes. But like all things, there are exceptions to every single rule. And navicular drop is going to be one of those exceptions when it comes to perhaps certain foot types that cannot tolerate minimal shoes, or maybe cannot tolerate minimal shoes all day, or maybe cannot tolerate minimal shoes when they run, right? Children, I actually just saw a patient today that had quite extensive navicular drop. And I was explaining to the parents about what midfoot pronation means and some of the contributors to that, and can they just strengthen their child's foot back into a neutral arch? So that child was an exception. So navicular drop is going to be one of those exceptions that I really want to set the tone and deepen your understanding of what are the outliers, or how do I appropriately address or recommend certain exercises, footwear, orthotics, arch supports for those that may have navicular drop or a excessive midfoot pronation. So that is kind of setting the tone of what we are trying to achieve in this webinar. But before we progress, I want to set a baseline of our anatomy, so everyone is on the same page of our rear foot and midfoot anatomy. For this, I am going to take off one of my shoes so that you guys can kind of join me as I identify the different bones on the foot and how they move. So when we look at our foot, it is broken down into a rear foot, midfoot, forefoot. So you have your rear foot, midfoot, forefoot. The rear foot is going to be your ankle joint with your subtalar joint. So ankle and subtalar joint is going to be the rear foot. That is going to be here. That's your tibia, fibula, talus, and calcaneus. That is your rear foot with the ankle and subtalar joint. Then moving forward into our midfoot, this is going to be the navicular, cuboid, and the three cuneiforms. Okay. It is also going to extend into the bases of the metatarsal. So your metcuneiform joint, we'll talk about that briefly, just so we understand the full base of it, but it's going to be the first met base articulating with the cuneiform that is still considered part of the midfoot. Okay. Now, the part of the midfoot from a midfoot posture perspective is going to be really around that navicular position or the talonavicular joint. Your other joint that we go into in our barefoot training specialist level 2 is on the lateral side of the foot, and that is going to be the cuboid with the calcaneus or the calcaneocuboid joint. But for the sake of what we're speaking about now, and for the sake of when I really reference midfoot with kind of that initial understanding of the foot or a layer 1, let's focus on the medial side. Let's focus on the talonavicular joint. So let's go back and let's together on ourselves identify the different anatomy, because when we move the midfoot, I want you to see how it's moving. Okay, so I am going to take my foot and I'm going to be identifying and drawing on my foot the different bones. So I have here with my pen, I'm going to put my thumb on my medial malleolus. This is going to be considered, or it is, your medial malleolus or your tibia, your tibia. Okay, now if you put your thumb on your tibia or your medial malleolus and you go down one thumb, there's an indent right there, and that indent is going to be your talus. So this is your talar neck. So that indent that you feel is actually the neck of the talus. You're going to go down another thumb, and if you go down that next thumb, you can feel that there's this bony prominence. If you shut your eyes and you feel the inside of your foot, the most prominent bone that you feel is what we just put our thumb on, and that is going to be your navicular. Okay, now if we continue from the navicular, we go down another thumb, and this is going to be your cuneiform, or sorry, your cuneiform, yes, my goodness, where's my head today? And then your first metatarsal. So we have our tibia, talus, navicular, cuneiform, and then our first metatarsal. So we're following along here on our medial column. So again, you have your tibia, talus, navicular, cuboid, first metatarsal. Now, right here, this talonavicular joint, that articulation is going to be what we're referencing. And I want you to put a big old circle around your navicular. Okay, so identifying that medial column is very important. Your navicular position is identified as the highest point of your medial arch. So when we look at the arch, the highest point of your medial arch is your navicular. So theoretically, when we say you have a high arch, you have a low arch, really what we are describing is your navicular position. So your navicular is sitting low to the ground, or your navicular is dropped. Obviously, we're speaking about navicular drop here, or your navicular position is lifted, which we'll find out is actually associated with more foot rigidity and a locked midfoot. Okay, so I just want you to understand those different positions. Here's we go from tibia, talus, navicular, cuneiform, first metatarsal, medial column. Talonavicular joint is going to be that midfoot joint that we are referencing. Now, the other joint in the foot that is part of your midfoot is your cuneiform first metatarsal, which is your first ray, and the stability of your first ray is greatly influenced by your talonavicular joint. So if your talonavicular joint is not stable, it then destabilizes the first ray, and then that's how you can get bunions. So you can start to see that correlation. Okay. So talonavicular joint, the highest point of the medial arch is going to be your navicular. Navicular position is associated with arch height, and that position, the navicular position, the talonavicular height, is supported by a ligament and a tendon. Okay, now there's multiple ligaments, but the primary ligament that is stabilizing your talonavicular joint is referred to as your spring ligament. So if we look here, this right here is showing you the spring ligament. So this is your tibia. This is the neck. So we were palpating, that's the indent, that's the neck of the talus. And then this is going to be your navicular. Sitting underneath your navicular and supporting the talar head and really the articulation of the talonavicular joint is your spring ligament. This is important and it will make a lot more sense as we continue, okay? But there's a ligament that is holding that joint up, okay? If anything happens to that ligament, the integrity and the capacity for that joint to stay lifted and stable is going to decrease. Okay, now you also have supporting your talonavicular joint in your navicular position is your posterior tibialis, which is coming down here. Okay, now your posterior tibialis, I'm just show you real quick on my foot so you can see it as well. So it comes here, runs behind the ankle bone, inserts on the navicular, and then fans out, and it attaches to the bottom of the foot like a hand. Your posterior tibialis is a really super cool muscle that has 9 attachments in the bottom of the foot. So once it attaches to the navicular and it fans out, it's going to attach to every bone in your rear foot, midfoot, and the bases of the metatarsals, except for the talus and except for the first metatarsal base. So it's a very kind of broad attachment coming across the bottom of the foot. It is also going to attach to your abductor hallucis muscle, and then it attaches to your pronator longus muscle. So you have a very broad attachment and influence of the posterior tibialis, acting as a very powerful supinator of the foot. Its primary insertion is on the navicular bone. So you could see just from this drawing that if we engage and we have optimal post-tib stabilization or strength, that muscle and tendon is going to lift the navicular bone. Okay. Now, the ability for the posterior tibialis to function optimally is based on the rear foot position. So if your rear foot is unlocked and you are collapsing into an overpronated position, you have essentially put the posterior tibialis and the tendon on stretch. And it makes it very difficult from a torque perspective, straight physics, for the posterior tibialis to get enough torque to then lift the foot into sufficient supination or stabilization. Okay, so it's just a little bit on how we stabilize the navicular, the talonavicular joint from both a ligamentous perspective and a musculotendinous perspective. Okay, all right. Now, your talonavicular joint and that navicular position, the way that it's moving, it's actually considered your second ankle joint. And this is something that we go into and over in the Barefoot Training Specialist certification is, why is it called the second ankle joint? Well, there are 2 reasons why your talonavicular joint is considered your second ankle. First is that evolutionarily, the primates' ankle is actually the talonavicular joint. So primates roll through their foot the way that we do through our ankle, but through their midfoot, which is why if you think of even like a cat or a dog, they have a pad back here and their ankle is sitting up here. They actually don't articulate through their ankle the same way that we do. Okay. Now, the second reason why the talonavicular joint is considered the second ankle is because the movements of your talonavicular joint are the same. The planes of motion and the joint coupling that you observe in the ankle, you also observe in the talonavicular joint. Okay, we're going to go through it. Okay, so we're going to step back and we're going to first talk about the rear foot, because you cannot fully understand the midfoot unless you have mastered the rear foot. Okay, so in our rear foot, you have 2 joints. You have your ankle and your subtalar joint. Your ankle joint, we think of this oftentimes as a kind of like a hinge, right? We do extension and flexion. We bring our toes up, we bring our toes down. This is called dorsiflexion. This is called plantar flexion, right? And when we plantar flex and dorsiflex our ankle, it is moving through the sagittal plane, right? Sagittal plane motions, dorsiflexion, plantar flexion, okay? Sagittal. However, even though we focus primarily on sagittal plane motion of our ankle, it is not purely a sagittal joint. It also moves in another joint and the other, or through another joint axis. And the other joint axis that it moves through can be determined by identifying the axis on ourselves. So what I want you to do is you are going to take your right hand and I want you to reach down and you're going to grab your right ankle bones, your malleoli. Okay, so I have my right thumb on my medial malleolus, my pointer finger on my lateral malleolus, and then I'm just going to feel the orientation and the relationship between those two bones. So if I were to shut my eyes and feel my medial and lateral malleolus on my right leg, can you feel that your tibia or the medial malleolus is sitting higher than your lateral malleolus? Can you feel that? Okay. And then can you also feel that your tibia or your medial malleolus is sitting in front of your lateral malleolus? So the orientation of your ankle axis is up and then forward. So it's like this. So if we were to bisect your malleoli, so I'm going to bisect my right ankle malleoli, it would actually be oblique like this. Okay. If our ankle was purely a sagittal joint, that axis would be directly like this, horizontal. However, because we are moving through not just one plane of motion, you actually get this oblique orientation. And then technically it's a little bit like that as well, okay? So you are technically getting all three planes through your ankle, but a majority of that range of motion in your ankle is going to be coming from sagittal and transverse, okay? Now in the foot and ankle, sagittal motion in the ankle is dorsiflexion, plantar flexion, right? Dorsiflexion, plantar flexion. Transverse plane motion in the foot and the ankle is going to be, I don't know if anyone knows, transverse plane motion in the foot and the ankle. Transverse plane motion in my shoulder is rotation. Transverse plane motion in my spine and in my pelvis is rotation. However, transverse plane motion in the foot and the ankle is not rotation. It is actually abduction and adduction. Okay, so AB, turning away from the midline, AD. So this is your transverse plane. And this is, obviously, we're rotating on the transverse plane when we are outside of the foot and the ankle. But in the foot and the ankle, it's going to be abduction, adduction. Okay. So when you look at your ankle joint, oops, I thought that it had said it, but it didn't. I apologize. So when we look at our ankle joint, what happens based off of the axis is that as you dorsiflex your ankle, it's also going to go out. When you plantar flex your ankle, it is going to go in. So the coupling or the motions of your ankle joint are dorsiflexion plus abduction. The opposite is plantar flexion plus adduction. And could you see that on your ankle? If you look at your ankle and you move it, and I'm kind of doing it, I'm dorsiflexing, but I'm going up and out. And then I'm going to go down and in, up and out, down and in. Can you see that motion on your own ankle? That is a couple. So if you're taking notes, I would want you to write down ankle equals dorsiflexion plus abduction. That's a couple. Plantar flexion plus adduction is the other couple. That is what your ankle does. Okay, Beautiful. Now we have to talk about your subtalar joint. The movements of your subtalar joint are going to be, we stand up, we can totally feel it. If you stand up, you can go to the outside of your feet, the inside of your feet, the outside of your feet, the inside of your feet, out, in. We're moving in the frontal plane. And these movements, inversion and eversion, are what we are going to identify with the subtalar joint, okay? So your subtalar joint is moving in the frontal plane, inversion and eversion. Beautiful. I just want you to write that down. Subtalar joint equals inversion plus eversion, okay? Right, this is what all we're doing is talking about the joints, okay? How they move, okay? That is your rear foot. Technically, I don't want to make it overly confusing, but I'm just going to say it. And if it's confusing, I apologize. Maybe listen to it again, or definitely go through the BTS certification. So when it comes to pronation and supination are considered triplanar motion. It takes at least two joints to pronate and supinate. So when I am referring to rear foot pronation, rear foot supination, rear foot, two joints, ankle subtalar, the rear foot pronation is going to be dorsiflexion, abduction, and eversion all at the same time. The rear foot supination, which is stabilizing of the foot, is going to be plantar flexion, adduction, and inversion all at the same time. Rear foot pronation is different than midfoot pronation. And remember, the focus of this webinar is midfoot pronation. So I think an important understanding is that there are two different things. When I say pronation, I need to give you the information of which part of the foot is pronating. Is it the midfoot or is it the rear foot, right? And you address them differently, okay? So that's our rear foot. Let's pause there and we're going to look at our talonavicular joint. We considered the talonavicular joint the second ankle. Part of the reason why we called the talonavicular joint the second ankle is because it moves through the same planes of motion as the actual ankle. And the planes of motion of our actual ankle are sagittal and transverse. Okay. So your talonavicular joint is going to do the same coupled movements as the ankle. And we wrote them down, right? So if I look down, I can see that the joint movements and the joint coupling of the talonavicular joint is going to be dorsiflexion with abduction, plantar flexion with adduction. They're married. Anytime your ankle dorsiflexes, it's going to abduct. Anytime your ankle plantar flexes, it's going to adduct. Same thing for your talonavicular joint. Anytime your talonavicular joint dorsiflexes, it's going to abduct. Anytime your talonavicular joint plantar flexes, it's going to adduct. Woo! What does this look like? Oh my goodness. Okay, so I'm going to show you on my foot what this is going to look like. And you can do this on your foot as well. I'm going to move somewhere so that I'm not on my carpet so you can see it clear. So I am here. Okay, you can see me here. Okay. I drew my navicular right here, circle around the navicular. It should be circled on your foot as well, right? Tibia, talus, navicular, circle it, put an X on it if you need, okay? Now what's going to drive the motion of your talonavicular joint is going to be your subtalar joint. So I'm going to just start by standing and I'm going to move my subtalar joint in the two motions that it does in the frontal plane, inversion and eversion. Inversion and eversion, invert, evert, okay? So we got our subtalar joint down. We understand that, okay? Now let's look at our talonavicular joint. I'm looking here. What happens to the talonavicular joint when I evert my subtalar joint? Well, you can see, right? This is the midline of my body. It just adducted towards the midline of the body. What is coupled with adduction? What in the sagittal plane is coupled with adduction? Plantar flexion or dorsiflexion? I hope you're saying plantar flexion. It's plantar flexion is coupled with adduction, just like in the ankle. Okay, let's do the opposite. Let's go to inversion. As I invert my heel, here's the midline. I'm moving away from it. Did you see it move away? And then what was coupled with it? Abduction is always coupled with dorsiflexion. Okay, so we have adduction of my TNJ, abduction, AD, AB. Okay, let's look from the side. Okay, now from the side of my foot, if I evert, right, can you see my navicular here, right? When I evert, it just went lower. It dropped, it plantar flexed. When I invert, here's my navicular, whoop, it just went up, right? It dorsiflexed as I inverted. So my navicular went down, my navicular came up. My navicular dropped and adducted. My navicular lifted and abducted. Okay, so the movements of your navicular and your TNJ are the exact same as the ankle, right? The planes of motion and the fact that it is coupled with your subtalar joint is the same as our ankle, okay? So it dorsiflexes, abducts, it plantar flexes, adducts, okay? Now it is associated with a subtalar joint motion, okay? The subtalar joint motion that creates plantar flexion in our talonavicular joint is eversion, right? So plantar flexion, adduction, eversion. Boom, here we go, right? That is midfoot pronation. Dorsiflexion, abduction, inversion, supination. Okay? Oftentimes when I teach this, and I do this in live courses, people definitely are like, okay, that was a lot. I need just a little break. I need a little break, okay? Now I just want to let it sink there. I want to put meaning behind this, okay? Because if you just memorize this and you don't understand the functional meaning behind it, then it's no good, right? So now what we're really talking about here is there's adjectives with the foot that are stable and unstable, or locked and unlocked, okay? Your foot has to be able to unlock to absorb impact forces and energy. But in order to release energy and power when we move dynamically, your foot has to be able to lock again. It has to become stable. It has to be a rigid lever, okay? So the locking mechanism or movement of the foot is supination. The unlocking or destabilizing movement of the foot to absorb energy and absorb impact forces is pronation. Okay, now supination and pronation are like on a scale. So every foot and everybody needs to be able to supinate and pronate, but the degree at which you do both has to be kind of fine-tuned and dialed in. If you supinate too much and you're an over supinator, then you are too rigid. And from a timing perspective, you cannot unlock your foot fast enough to absorb impact forces. Conversely, if you are too pronated, over pronated, then that means that you have too much laxity or unlocking in the foot. And from a timing perspective, you cannot stabilize your foot in time to create sufficient power. And then you get other injury patterns as well. Okay, so supination, pronation is normal, but you have to understand it has to be dialed in. I understand that when you may see people will make posts, especially on our fabulous social media, and say, oh, but pronation is good. We need to pronate. You do, But there are many people who overpronate. And the reason why they overpronate is not just because of bad shoes and the bad shoes cause muscle weakness. That's not always the case. There are some structural reasons. I also want you to understand and to ask yourself, when someone is overpronating, are they overpronating in the rear foot or in the midfoot? Right? And what's the difference? We are focusing here on the midfoot pronation. Okay. Now, midfoot pronation is also known as navicular drop, right? Because the drop is the plantar flexion. When you pronate in your midfoot, your navicular has plantar flexed, dropped. That has unlocked and destabilized your midfoot. If you destabilize your midfoot or your talonavicular joint, that destabilizes your first ray, which then destabilizes your first MPJ. So we start to get this domino effect through the foot when we start to see further unlocking. One of the most common contributors to midfoot pronation and unlocking of the midfoot is rear foot, because one affects the other, and becomes this domino effect, right? So we're going to be talking about, what does this mean, right? How do we apply this? What are some of the causes? How do we help our clients or ourselves who might have this, right? And then where do orthotics come in? Possibly, right? Okay. So when you are truly assessing navicular drop, this is an assessment that you want to do. This is not something that you just look at someone and just kind of, oh yeah, I think that's severe navicular drop. No, we need to actually measure this, right? We need to see what is happening in the arch, what is happening to our client's arch as soon as they bring gravity and force through their foot. Does it have sufficient lift to create stability? Okay. Now, when we do a navicular drop assessment, you're essentially doing 3 measurements. Okay. Your first measurement is going to be open chain. And again, we teach this formally. The intent of this is not to make you an expert in navicular drop, because we got 45 minutes and that would be awesome if I could make you an expert in 45 minutes, right? But this is something that we go into in our Barefoot Training Specialist Level 2 courses. I teach you how to do the navicular drop assessment. We do it in person or obviously over our virtual training. But the navicular drop, the first measurement that you're doing is going to be open chain. So if you were to look at your client's arch, right? So I'm looking at the foot open chain, I'm looking at it here, okay? And I am going to mimic the ground. So I need something, right? This, just for the sake of this, let's say we have a book. So I'm going to be measuring the navicular. Here's my navicular position. I'm essentially measuring my navicular height from here to what is mimicking the floor. This is the floor. The book is mimicking the floor. So that distance is my measurement number 1, right? Okay, so we would have that. That's our first measurement. Now, on an open chain like this, non-gravitational perspective, relaxed arch height, a 3.5 to 4.5 centimeters in average arch height. That is the arch potential that your client has, right? I'm not on gravity yet, so that's the potential. I hope that I can support my arch to that as soon as I put body weight and gravity on. Your second measurement is going to be feet shoulder width apart in what is called relaxed calcaneal position. So I just stand up, and this is what our feet are when we stand with our feet shoulder width apart, just relaxed, okay? That is going to be the second measurement. You are measuring from the floor up, okay? And just for the sake of making sure we got lots of information here, I would be measuring from here to here, okay? And again, this is, you will not perfect this in a 45-minute webinar. So we're measuring here. How much did it drop, okay? And then your third measurement is to go from 2 legs to one leg. So you're doing a single leg stance. Now, the reason why I take a client or a patient through both a bilateral and a single leg is because a bilateral stance position is technically considered relaxed. As soon as you shift from two legs to one leg, you have just engaged your intrinsics, your post tib, your glutes, all of these fascial single leg stabilizers, that your navicular should actually lift because you are active, okay? So what we are looking for is, from an open chain perspective, no gravity on that foot, what is their baseline? As soon as they put gravity on both feet, nice and relaxed, what happens to that navicular? Does it boom and it bottoms out and it drops? Any drop between measurement 1 and measurement 2 that is over 10 millimeters is considered pathological. Now we'll go into what does pathological even mean, right? But is considered pathological. Now, if you have the client go from two leg to one leg and they get a lift again in that navicular, that's good. That's what we want to see, okay? Because a single leg stance is an active foot position, okay? So let's go into a couple scenarios here, all right? So we measured from open chain to standing on both feet. Let's say, boom, they both dropped 10 millimeters. Oh my gosh, we are pathological. We have a pathological navicular drop in midfoot pronation. This is not good, right? Then you have the client go into a single leg stance and it lifts 5 millimeters, which means the drop in the navicular in a single leg stance is 5 millimeters, right? It went down 10, up 5, so 0 to 5 millimeters, you got 5 millimeters, right? You want to see at least a 50% increase in navicular lift when someone transfers from two legs to one leg, okay? Let's say, nice and relaxed, no gravity. I stand on both feet. My right navicular dropped 8 millimeters. You say, okay, I got it, 8 millimeters, not bad, okay? It's pushing 10 millimeters, but you're not there yet, okay? Let's see what happens when you stand on one leg. They transfer to just the right leg and it lifts by 4 millimeters. So they could lift it at least 50% of what that drop was, okay? Love it. I'm happy with the baseline function of that foot and the talonavicular joint in that individual, okay? Now, let's consider another scenario, okay? Measure the open chain, and then they stand on 2 feet and it drops 10 millimeters, and you say, okay, stand on just your right leg. I know it dropped 10 millimeters, but stand on the right leg. Let's see what happens when you become active. It didn't move a millimeter. It stayed 10 millimeters down. There was no increase in navicular position. What does that mean? That means that they have hit that pathological navicular drop, whether they are in a relaxed or an active position. This is going to make me, from a clinical perspective, very strongly consider talking about orthotics, okay? Because if there is no ability or capacity or movement observed in that navicular as they go from passive, active, 2 leg, single leg, then they are potentially at risk of having transfer stress to the knees, hips, lower back, etc. Okay, so you want to see, just because you see a drop when they go to 2 feet, your assessment is not done, because if by the time they go to one leg, they can still lift it, then I don't jump to orthotics right away. It really is the individual that when they go from 2 legs to 1 leg, there's no movement in that navicular position. And that is many times because of a ligament laxity, or they have potentially torn their spring ligament. Okay, so let's take a look at a couple of these pictures here. All of these individuals are presenting with what would be considered midfoot pronation. They have navicular drop, little bit different severity on all of them. Some of them may be symptomatic, some may not be symptomatic, okay? However, when we look at I'm going to start in the center just because it's right there and it's bold right in front of me, okay? So this person has had surgery. So this is actually a foot that probably very highly needs surgery. This was a flat foot reconstruction, and I can just tell based off of where the incisions are. But on their right foot, they have a neutral foot. We can see here that there's obvious eversion in the subtalar joint, right? But you can see all of this bulging, right? So if you were to look at this and not even just say, just off the bat, like, yeah, that's not a good foot, but let's actually break it down and understand it, right? Right here, if this is the midline of the body, we want to appreciate this right here is about the navicular, right? That talonavicular joint. Do you see the adduction towards the midline, right? The right foot does not have adduction of the midfoot into the midline, right? So that bulging inward is adduction. Adduction is coupled with plantar flexion. So I know that this individual's left foot is dropped and in. Midfoot pronation, navicular drop. Now, just based off of me knowing exactly how this type of foot is going to move, I can almost guarantee my license that this is a rigid midfoot. So it's a rigid, arthritic, overpronated foot with a midfoot collapse, and it actually does need to have a reconstruction. So any orthotic is not going to correct that foot, which is why they probably had surgery on that right one, because they both probably presented similar. This foot on the left and this foot right image are flexible feet still. But here you can appreciate, do you see this bulging towards the midline? Can you see that it dropped? Okay. Now a foot that has this degree of midfoot pronation or navicular dropping is very, very difficult to correct and reverse with exercises. It's extremely difficult. I would probably put it as probably impossible to correct that with corrective exercise. Now, that doesn't mean they don't do corrective exercise. It just means that we have to understand the realistic expectation for that individual on how we guide them and recommend. So as soon as something becomes into the midfoot, a midfoot pronation, I will then start to have the conversation of using orthotics or arch supports appropriately. It doesn't have to be all day, every day, but it could be when you stand at work for your 10-hour shift as a nurse. I do want you in an orthotic because you are just starting to get chronic plantar fasciitis and low back pain. So I'm going to support you because I understand that the reason why you're getting that stress is because of this midfoot laxity. Okay. Now, the biggest question that we get is it functional or structural? If something is functional, then that is where we're looking at how we can correct it or reverse it, right? Functional is usually that there is a lack of muscular engagement, connection, etc., or muscular integration. Whereas structural would be more ligament laxity, a torn spring ligament. Maybe they have a tear in their post-tib tendon. So things have either progressed a little bit more towards a chronic state, or like in the case of the child that I saw today, his foot was very similar to this. And as a child he happened to be 7 years old, and a child at 7 years old, I know that is a ligament laxity because that is the #1 cause of moderate to severe overpronation and midfoot dropping in children is ligament laxity, right? So understanding that structural side for the child helps me explain to the parent why they need to be in the orthotic and the purpose of the orthotic for the child. Again, we still do our exercises, okay? So the most important thing is that we want to be able to find a balance between foot strengthening and foot support. So in any of the cases that I just showed, whether it is strength or ligament laxity, I would recommend orthotics to them. Now, the orthotics could be custom. They could be something over the counter like a power step. I would recommend putting the Naboso insoles on top so that you still have that active sensory stimulation to the foot, even though having the power step or the custom orthotics. And then we would still integrate and do short foot exercises, find neutral, foot to core. You should be able to rotate your foot into a neutral position and then do your bicep curls and whatever your exercises are doing barefoot, and you could still do it. But it's going to require the conscious awareness and the cueing to set their base. As soon as something becomes subconscious, such as walking, running, and other repetitive movement patterns, the individual will most likely need to be using an orthotic to help support the foot. Okay, but again, it's finding that balance. So you can absolutely still do minimal shoes, right? I would say, okay, maybe don't wear minimal shoes if you have a midfoot pronation and you have active plantar fasciitis all day, every day when you go to work or when you run, because you're not matching your foot type, right? Your foot structure, not just the foot function, but the foot structure, okay? Number one cause that I see contributing to midfoot pronation is a ligament laxity, and you cannot override ligament laxity with muscular strength. You cannot, right? Again, you cannot override ligament laxity with muscular strength. You have to have that baseline ligamentous integrity, and then the muscles contract on the base at which they support. Okay, so just a really important distinction that I want you to understand. Okay, these are a couple more examples of pronation, midfoot pronation, some of that navicular drop here on the right. You can actually see her navicular, it's prominent, right? So that would be considered mild. Okay, so if you're wondering, okay, what degree do you start to push people into orthotics? This foot on the right could absolutely get away without using orthotics. She has a mild navicular drop. My guess is when this individual with the black tights on goes from 2 legs to 1 leg, I bet her navicular position would lift on her left foot. And then I'd say, okay, you know what? We can continue to follow it, right? Keep strengthening your foot and make sure you maintain, optimal foot health and foot to core integrity, because, if you neglect your feet, could you get more navicular dropping? Absolutely, right? So for her, I would say focus just on strengthening. You don't necessarily need to do orthotics. The individual on the right here with the jeans, you could see that this right foot is more pronated than the left foot, right? So my guess is her right navicular is dropping more than her left navicular. When she goes onto a single leg, my guess is she's probably not getting sufficient lift to the navicular. I would probably have a conversation of arch supports for the woman on the right, but I would still for sure incorporate foot strengthening, daily foot releasing, understanding how to set your base, how to find neutral. If she was very anti-orthotics and had absolutely no injury history and no symptoms whatsoever, then I would say, okay, I understand that, but I'm going to educate you on your foot type. And because of your foot type, you're a little bit at risk of stressing your foot. So if you're not going to use arch supports, which I totally respect, then I need you to make sure that you're really focusing on your foot strengthening and having good, consistent foot awareness and being tuned into your movement so you don't get injured, right? So it's not that as soon as you see a foot like the woman with the jeans, that for sure they need orthotics, right? Because she could maybe get away without doing it. But that's where I want you to kind of start to understand, what are you seeing, right? What is the foot type? Is the pronation just in that calcaneus and in that rear foot? Or are we actually seeing some navicular dropping? If I'm suspecting some navicular drop, then I really should measure it, right? So that I'm not just guessing. I actually have a number. Again, we go into this in our BTS level 2. I'm measuring how to do that navicular assessment, and then I can guide them to either use an over-the-counter arch support or just focus on exercises, or I'm going to refer out to custom orthotics based off of how much I'm seeing. Okay. And then, of course, if there are symptoms and they have plantar fasciitis or post-tib tendonitis, then we always want to factor that in as well. Okay. Obviously, navicular drop in midfoot pronation puts someone at risk for plantar fasciitis, post-tib tendonitis, shin splints, Achilles tendonitis, medial knee pain, bunions. So it can start to progress into other injury risk. Okay. Whoo! Lots and lots of anatomy and biomechanics, everyone. Oh my goodness. All right. Well, we are doing a discount on our BTS level 1 and 2. These are found on our online school, which is ebfaglobal.teachable.com. If you use code webinar, you will get $100 off. That is through the end of the month. So make sure that you take advantage of that code webinar. You'll get $100 off either of these courses if you sign up before the end of January. That is the URL. And I will open it up to any questions that you may have. And if for some reason you do need to go, obviously because of the time, I did go a little bit longer than I thought I would from a content perspective, but it is all for your benefit. Then please do just listen again. All right, so Michael has a question. How does the presence of an accessory navicular affect the load attachment of the post-tib? Great question. So an accessory navicular is an accessory bone that sits right on that navicular. And what it does is, let's imagine this is the navicular and then this is your accessory navicular. Your posterior tibialis comes down, and instead of attaching here, it attaches here on that accessory navicular. So Michael, and for everyone, you have essentially changed the lever arm of the posterior tibialis, and you've put it in a slight mechanical disadvantage. So individuals with accessory navicular are a little bit predisposed for post-tib tendonitis. You'll actually see the midfoot pronation oftentimes more in them. They could get shin splints, plantar fasciitis, some of the other injuries, but it definitely does change the mechanics to the posterior tibialis. Great question. Andrea says, your name is in the way of several of your demos. Can you remove it? Sorry, I'm just seeing that. Sorry, I don't know where my name is. It doesn't show up when I'm looking at the camera. So my apologies to everyone and to Andrea. I do apologize that I just saw that now. Terry says, what is the potential cause of this drop? I'm seeing a lot of this type of cases in youth and young teens. Number one cause that I see of this is ligament laxity. Ligament laxity. Ligament laxity is genetic. So having a flat foot in itself is not genetic. It is the connective tissue integrity. So you can actually see more changes in the collagen fibers in some of these individuals. That's the ligament laxity that we're going to identify as such. And yes, then ligament laxity is structural and cannot be overridden through just foot strengthening. That is where you would have the conversation of, do we need to be in orthotics or some sort of arch supports? Okay, Terry, so that's an important differentiation there. Now what can happen is that chronic dropping of the talonavicular joints. So you're pronating chronically through your midfoot. Remember, you have your spring ligament here. If you push into a ligament or any tissue over and over and over and year after year, you can start to lengthen it and then tear it. So someone who presents the way that some of these feet did is Let me just give an example here real quick. If this person, just here on the left, I'll say, if they chronically walk on a foot like this and run and jump and say, don't use orthotics, and they do that, they very easily, year after year, they could tear their spring ligament. If you tear your spring ligament, no strength in the world to the posterior tibialis can lift that navicular up to the point of sufficient stabilization. So if you see it, particularly in adults, I know, Terry, your question was about teens, but in adults with a substantial navicular drop, they might actually have a torn spring ligament, okay? And then this anatomy that I had shown earlier, this one right here, this is actually showing a surgical correction when someone has torn their spring ligament. That's essentially what that image is demonstrating. So this would be the surgery for a torn spring ligament. Okay. Andrea said, yes, no, I know it is, but I actually don't see it. So when I'm looking at my video, Andrea, I don't see my name under it. So I can't tell you I can't see what you're seeing. So hopefully that makes sense. Okay, perfect. Any other questions? You are very welcome, Michael. So definitely let it process. I know it can be a lot. You might be saying like, I need to listen to this again just because it was so much. Definitely listen to it again. We're going to send the recording out to everyone. Carmen says, which sports produce spring ligament tears? It's actually not sports that cause the spring ligament tear. It is a chronic dropping of the talonavicular joint. Any sport that is associated with ballistics. So let's say someone is doing triple jump. I'm just making this up. Triple jump, and they have a foot like the examples that we showed. There's obviously high velocity force going through that foot. They do it year over year. That's going to cause stress to that spring ligament. But it could just be someone standing on their feet for work, and that's what their feet look like, and they don't have support in their shoes, and it's just chronic stretching and lengthening of that spring ligament, and eventually it could tear. So it's just repetitive arch compression. Hope that helps, that it's not dialed into just one sport. Andrea says, do you have an audit price for those of us who have done BTS level 1 and 2 and want to review? Absolutely, yes. So there is 50% off on that. So you can enter code audit and it will take that discount off. So you can absolutely audit any of our courses. If you have completed them, then just sign up and you're essentially going through it again. We also do allow you to audit a live course now that the world is opening up again. If you do take an in-person live course and you took it online, you can actually audit it in person. So that's actually a cool feature as well. Okay, you're so welcome. Perfect. Good. Well, I understand the time difference. Thank you guys so much for staying on. Really appreciate it. I'm actually going to do one last question and then I'm going to let everyone go just because there was one last one that came in. Does measurement number 3 of the navicular drop dictate if you want to prescribe orthotics, and if so, at what measurement? Yes. So if you listen back again, okay, so what I had said of that measurement number 3 is the determinant of do I recommend orthotics or not. And what I'm looking for is the percent change. So it's not just the number of how much is it dropped, but how much did it change from 2 feet to 1 foot. So when you go from a bilateral stance to a single leg stance, I want your navicular to lift. And what I'm looking for is a lift that is at least 50% of where it was when you were on 2 feet. Now, technically, the drop that is considered pathological is 10 millimeters. So if you are standing on 2 feet and you have a 12 millimeter drop, and then you stand on one leg and it lifts 2 millimeters, which means on a single leg stance, your navicular is dropped 10 millimeters. It was 12, It went to 10 when you went on one leg. It still is within that 10 millimeter being pathological here, right? So I would still recommend orthotics to that individual. Real quick, you stand on 2 feet, the navicular drops 8 millimeters. 8 is less than the 10 millimeters that is pathological. So I'm actually not going to rush to orthotics, not until it hits the 10. If it goes from 8 millimeters and you switch to one leg and it goes up to 6, even though it didn't increase 50%, I still actually feel pretty comfortable, and I'm going to suggest foot strengthening and then continue that way. Okay. Great question. Great question. Perfect. All right. Awesome. Well, thank you guys so much. I really, really appreciate your time. We're going to be bringing back all of our EBFA webinars. So do stay tuned. Once a month, we're going to be doing these just so we can continue to explore and expand our understanding of the foot, especially when we start thinking about some of these more complex, advanced concepts. So, do stay tuned. I know a lot of you have been following EBFA for a while, and it's time to up that intensity or the level of that content. So definitely stay tuned. Thank you guys so much. Have a wonderful day or evening, depending where you are, and I will see you soon. Take care.